My name's Kelsey, and I'm currently a medical student at Harvard Medical School and a Wake Up Narcolepsy board member. I was diagnosed with narcolepsy with cataplexy in 2018, shortly after graduating from college, and I've been involved with Wake Up Narcolepsy since about 2019. I'm currently doing a research project on narcolepsy and pregnancy with doctors Tom Scammell and Maggie Blattner, and I'm so excited to be here today to moderate this discussion on narcolepsy and maternal health. With that, I'd now love to pass things off to our wonderful panelists so that they can all introduce themselves. Emily, why don't you get us started?
Great. It's so good to be here. And thank you to Wake Up Narcolepsy for bringing attention to such an important topic. And I hope those who are here can go away with some great resources and ideas for moving forward wherever you are on your narcolepsy journey. I have had narcolepsy since I was 20 years old, type 1 with cataplexy. I'm a mom of 3 boys, ages 13. I just became the mom of a teenager, 11 and 6. I have really enjoyed engaging with this community as a co-facilitator for one of the peer support groups, Pregnancy and Parenting with Narcolepsy. That's been a really meaningful way to connect with a lot of people with narcolepsy on this journey, facing a lot of questions. And I've learned so much and kind of look at my experience differently retrospectively, learning from so many of you. I am also a scientist and a medical writer. I've been able to perform some research in medication use during lactation with narcolepsy. I like to stay active, and one of my favorite things is to play different sports and coach sports for my kids. So it's great to be here, and I look forward to our time together.
Thank you, Emily. Ashley, please introduce yourself.
Thanks, Kelsey. And just like Emily said, I wanted to thank Wake Up Narcolepsy for having me here today. I'm really excited that we're talking about this topic, and so I know it affects so many people. But my name is Ashley Starr Frechette. I live in Massachusetts, and I have had narcolepsy since I was 16. I was diagnosed when I was 18, probably. So I've been living with it for almost 20 years now. And I have type 1, so I have cataplexy. And I now have 2 boys. So one is 3 years old and one is 7 months. So this is right on my mind. So I'm glad that we're doing this topic here today. But my day job is I work as the Director of Health Professional Outreach at the Connecticut Coalition Against Domestic Violence. And I'm just really excited to talk about this topic. Like Emily mentioned, I've found so many connections through those support groups that Wake Up Narcolepsy offers, and just being able to meet everyone else who has narcolepsy has been extremely helpful. So thank you for having me.
Thanks, Ashley. Dr. Sharkey, please introduce yourself.
Hi, everybody. I want to echo everyone else's comment that it's a pleasure to be here, and I'm honored to participate in this webinar. I am a sleep medicine physician in Providence, Rhode Island. I work at Brown, and I have been in practice sleep medicines for almost 17 years. And so I'm the honorary auntie of many children of people who live with narcolepsy. And I'm just happy to offer my experiences and what I've learned from my patient, like you said, Emily, what I've learned through caring for people who are living with narcolepsy during their parenting journeys as they've been growing their families.
Thank you so much. Well, I thought we'd get started sort of talking about sort of before pregnancy, and as people living with narcolepsy, how you sort of approached your decision to become pregnant, your decision to raise a family, and how sort of narcolepsy affected your decision making.
I'd be happy to weigh in.
Yeah.
I think this is a great question for discussion, because I have sensed in the community that oftentimes this is well, it's always a concern, but often I feel like I encounter individuals who have kind of decided this couldn't be for me. It feels so impossible. And I'm not going to discount the dilemma that it is. It's kind of oftentimes it's a decision that has to do with, changing your medications, and you're dependent on your job for income or insurance. And it feels so daunting. And then on the other side, of course, you have the concern of what you might expose a developing fetus to and have no idea of what the implications could be. And so for myself, I didn't have narcolepsy until young adulthood, and I had always intended to have children, and I didn't feel like narcolepsy would deter me from that. And I felt like I leaned a lot on the prevailing opinions of my healthcare professionals at the time and the decisions that I made. I think what I've learned observing others in the community, and now that I feel like there's more information around this, is just some of the keys to success that include, like if you have time to have forethought on the topic, like thinking about who your support system is, and also working closely with both your sleep experts, but also working with OB professionals to kind of come up with a plan that works for you. And I've seen now so many examples of parents thriving with narcolepsy, but their journeys all look so different, whether it's on medication or off medication, single parenting versus parenting with a partner versus, but I just want to reiterate that it can be done. Everybody does it differently. And it's never too early to start thinking about it. In the support group that I help to facilitate, we have so many people join who are far from actually considering conceiving, but I'm so happy that they come, because that's the time to start thinking about it if you can. And I know it's also often on parents' minds of like teens or young adults. And I think there are a lot of resources for you out there. So a few thoughts. Go ahead, Ashley. I'm sure you have some too.
Sorry, I muted and then it wouldn't let me unmute. So yeah, I mean, I pretty much echo everything that Emily is saying. But I think one of the biggest things I learned from just participating in those support groups through Wake Up Narcolepsy around pregnancy was just how many people are kind of told that similar story where like when I was much younger, obviously when I was first diagnosed, I remember when I was trying different medications to see what would work best, like just the doctors like kind of getting in your face and saying, you can never have a kid on these medications. So it was just like, I was young enough that I was like, well, I never thought that would, you kind of just grow up thinking, okay, I have that choice to make for myself. So I think I kind of made that my mission through all of this, like Emily said, to try to work out things early, because I didn't want to have that feeling like, oh, you just can't do something because there isn't enough research or whatever. So I think that's what a lot of people struggle with. I think it's really hard to get all your providers that are involved to understand every side. I mean, I'm a huge advocate for myself being a narcoleptic. So all of my doctors happen to know about that. But when you try to communicate the different, topics, like, I'll tell my OB/GYN about these narcolepsy things. Well, I don't focus on narcolepsy, or like I tell my narcolepsy doctor about, trying to have a baby, and it's like, well, that's not my specialty. So I think it's just really hard to, first of all, decide, medication wise or not, and then also to get every provider that you work with on board. So definitely worth ensuring that you get that information as early as possible. And I can talk about the services that I use, but I don't know if you want me to go into that yet, Kelsey.
Yeah, maybe tell us a little bit more about the sort of types of doctors you found particularly helpful in sort of helping you plan for your pregnancy.
Great. Yeah, so the most important thing for me, like I said, was I've always been pretty open about my narcolepsy, but I kept feeling very frustrated with, I didn't feel like there was enough studies on certain things, or when I would bring something to a doctor, they would say, well, you know, there's just not enough information. I mean, it's a very small study. It's a very small study. So I knew that wasn't going to change. It's not like there's all of a sudden going to be all this research on narcolepsy and pregnancy that was going to change. So because I couldn't really get my narcolepsy doctors and my OBs to speak together, I thankfully had a really great OB at the time who referred me to this resource in Boston. It's at Mass General, and it's a really great resource if, you know, even if you don't live around here. It's the MGH Center for Women's Mental Health. And you can go on their website and you can see all the different topics that they research. Their primary task is helping any parent, any birthing person that is having a child, but maybe is on different medications or maybe is using substances. So a lot of their research obviously is mostly on like very hardcore substances, but many of them kind of relate back to some of the ones that some of us are on. And then, you know, you can even put narcolepsy in their little search bar and you'll see some of their research that they have. But they were like a game changer for me because they sat down with me and they had printouts of all these research papers. And instead of making it feel like it was 100% on me to make these decisions off of these like scientific papers that I wasn't necessarily, you know, sure what the answer should be. They at least kind of armed me with all these resources just to make a definitive answer, yes or no. And they worked with me on, you know, connecting me with a maternal fetal medicine person and then deciding, you know, what I wanted to do, which was to have just take one medication, which was like heavily researched, and to try that for my pregnancy just on a lower dose. So it made me feel so much more comfortable. And I brought that to my narcolepsy providers and all my other providers, and everyone was like, yeah, sure, this is great. So it was just like needing that, you know, piece of paper to feel like you were validated in your decision, I guess. But it just really helped to have that like peace of mind to know that there is some research out there and people have done it. And it was just a really, really helpful way to kind of collaborate everything that's put together. And then they helped write that letter to my doctor and pulled them all in and they all spoke. So it was a really helpful experience.
Wow, I'm so glad to hear that you had that experience, and wish that was sort of the normal way that doctors communicated with one another, but glad it's out there. Dr. Sharkey, I'd love to hear sort of how you approach these conversations with your patients with narcolepsy who are thinking about becoming parents.
Yeah, terrific. So first of all, I really try to bring this up, like Emily was saying, early and often, right? So almost when the first time that I, you know, confirm a diagnosis with someone, I'll say, and, you know, this might not be on your mind now, but just so you know, I say the same thing I said when I introduced myself. I'm the honorary auntie of a lot of people who were born, you know, little ones who were born to people living with narcolepsy. And so I've helped people during pregnancy and postpartum, like just to open the door, because you don't necessarily want to assume what people are going to do, but also, you know, they may not have been thinking of that. And then, you know, people want to grow their family when they want to do it, right? And it can be the farthest thing from your mind. And then all of a sudden, it is exactly what the right time. So I think some of it is, you know, just mentioning it ahead of time. I try to provide people with some of the research papers, like you mentioned, Ashley, and talk about some of the findings. So, for example, you know, there's lots of worries about medication, but there are certainly good data about some medications being, you know, presumably safer than others based on large sample sizes. It's not always in people only living with narcolepsy. So for example, many stimulants that we use in narcolepsy are also used for ADHD and are used off-label in other conditions. And so there are big databases and health records that can be used to look at safety measures. So some of it is talking about that. I'm an internist and a psychiatrist by training, and I know some of the people that Ashley mentioned at MGH, and I think psychiatry has really led the way in a lot of these conversations about whether it's better to take or not take your medications. You know, if we were talking about diabetes, nobody would be like, so we want you to stop your insulin because your baby might be a little smaller, right? So somehow the idea that this is a less worthy condition for continuing to treat mom is puzzling to me, but that's where especially we were, I think, 10 years ago. But over that time, there's been many papers published that showing, you know, who has healthy babies? Healthy birther, like healthy parents, right? Healthy moms. And so either under treating or not treating moms for any chronic condition appears to be sort of the suboptimal approach. Not to mention if it's not their first pregnancy and they've already got another little one at home, or, you know, and, you know, I think we make a lot of assumptions. You mentioned, Emily, people who are single parenting. So you may have a job that you have to go to you know, to keep your benefits so you can have this baby, you know, keep your health insurance so you can have this baby, all those things. So there's so many factors. And the idea that you just go off of the meds and kind of grit your teeth and be not well, I think that's like an older perspective that we don't share, that most people don't share anymore. So, I mean, those are some of the things. And then sometimes people have specific fears, you know, is my baby going to have a, you know, some kind of defect, or are they going to find it? But you know, I looked this up before the webinar. So 3% of pregnancies have some congenital malformation, but only between 2 and 4% of those do they ever find out what caused that. And so that's, you know, it's a very low likelihood that that's going to happen, number one. Number two, attributing it necessarily to medications, I don't think is accurate. Third, 90% of pregnant people take some sort of medication during pregnancy. So people are exposed to all kinds of things. So I'll stop there for now, but I think we're sort of doing some myth busting and debunking of people's worries. And then, Emily, like you were saying, for people that were like, well, now this is off the table for me, just really also saying, no, if you being a parent is on your bucket list, then we got you.
That's such a refreshing perspective. Thank you, Dr. Sharkey. Sort of that emphasis on healthy mom and healthy baby instead of just, you know, the risk to fetal development, I think is so important. Emily and Ashley, I'd love to hear you share more about your approach to medications in your pregnancies and how you both sort of navigated those decisions while working with your doctors and what ended up working for you. Maybe Emily, you can get us started.
Yeah, I'll take a turn. And I just wanted to thank Katie for some of the really important things that you said, and how much I hope that like clinicians can pick up on this. And because I agree that perspectives have changed and are changing, but it is still not uncommon to express an interest and a hope to grow a family and to be told, well, of course, you can't stay on your meds. And I think, and I'm not here to advocate one or the other. I'm not here to advocate anything. What I advocate for is conversation and shared decision-making. So my experience being young and being in, I think, a different world as narcolepsy goes and patient advocacy, that my thinking was pretty black and white. It was, you either take your meds and you risk exposure, or you go off of your meds and you muscle through with unmanaged symptoms. So I myself was off of meds, and I had 3 different pregnancies and 3 very different experiences, and I can weigh in a little more on that, but it was me seeing that as the safest option, but that was strictly from the perspective of a developing fetus and not from my own safety and well-being, you know. And I don't know, there's a little disconnect there because my safety is also very closely connected to the safety of what's growing in my uterus. So having spent more time in this community and going back, I would have had this be a much more ongoing conversation, because I think, like I said, it seems black and white, but there's also different stages of pregnancy and different levels of risk to exposure. And so it might mean it might mean that I would have chosen to have reduced meds or no meds, and seen how, and evaluated how I feel, how I'm doing. And if it's a more vulnerable time of the pregnancy, maybe I'd say, okay, I can do this for a trimester and then try something different. Whereas unfortunately it was, okay, to my sleep provider, I'm pregnant, I'll call you when I stop breastfeeding, you know? And we were out of touch for like a year and a half. And so I think that that is a principal regret, was that there wasn't an ongoing conversation, that I wasn't even seeing my sleep clinician, who might have been asking, how are your symptoms? How are you doing? Is anything changing, you know, throughout the different trimesters? How is your driving? How, like, do we need to address anything? So that's a regret of mine. And that's an advice that I would give to others, is to, like I said, you start the conversation early and you don't plan to end that conversation, that it's something ongoing, and that you don't have to make a decision that you stick with. You know, it's something that can change as symptoms ebb and flow. And I mean, I think there are some medications that it is difficult to like start and stop, but a lot of people are utilizing options that can be initiated and stopped pretty immediately. So those are some things that I've learned, and how my experience was.
Thank you, Emily. And I almost wonder, you know, it sounds like it might have even been helpful if your sleep doctor had told you, like, hey, let's check in at some point during your pregnancy.
Totally.
And maybe that's a takeaway if there's any other physicians in the audience here. Ashley, how was your experience sort of making these decisions about medications in both of your pregnancies?
No, thank you. So like I said, when I was younger, I just had made it like a goal to figure out how I just assumed like I could not live without my medication. Like I just don't function. I mean, I hold our insurance for our family. Like I need that money to pay, you know, for my house. And so I couldn't drive, obviously, if I didn't have my medication. So I just was like really adamant about trying to figure out a way, if there was a way, to be able to take my medication. So I was very grateful for the time that I got to work with this MGH group and getting all that research that they had. But so my first pregnancy, I had a miscarriage very early on, and I knew nothing about miscarriages. And so I clearly blamed myself, because it was probably because I was on medications. And, you know, all of my doctors and everyone I've met since, like, now that I've learned how common miscarriages are, like, that, you know, there's very little chance, like Dr. Sharkey said, that is the reason. It just was a very early on pregnancy loss. And, you know, we unfortunately have that a lot, but just isn't really talked about. But I was very thankful, because at the time I was on a medication that I didn't know how it affected pregnancy. And we thankfully got those letters. So I'm super thankful to any pharmaceutical company that takes the time to make a registry, because I did switch off of a medication that could have caused, you know, congenital heart defects to my child, just because like they took the time to have that registry. So I did really appreciate that. So I did work with that MGH team. I, at the time, was taking 2 different medications. I landed on just taking Concerta, because they just wanted one medication to present to the body. And we went as low as I could go to still be able to drive and, you know, function to the best of my ability, with lots of naps and things like that. So I did choose for both pregnancies, and for both of my sons, I breastfed on that low dose of Concerta. So I always have that fear that something would, you know, go wrong, and it makes you nervous the entire time. But I felt less of that with my second pregnancy, because like once I had that information in hand and I could advocate for myself, I feel like no one seemed to care that I was on those medications. And they're like, no, you know, lots of people are on these, or on way higher doses, or things like that. So it made me feel so much better. And I mean, both my boys are very healthy and happy. And so I'm grateful that I was able to keep myself healthy and happy, because I just can't imagine what my cataplexy would be like, how my work would, I mean, I would have been fired, I'm sure. So I was thankful for that opportunity to have that option to take some meds.
That reminds me so much of what Dr. Sharkey was saying about like healthy mom, healthy baby, and just some of these realities of you're still a person living your life, and you still got to go to work, and you still got to drive there, and you can't just sleep all day. So thank you, Ashley.
Oh, sorry.
Oh, yeah, I was going to pass it on to you, Dr. Sharkey, to see if you had anything you wanted to add about how you sort of help your patient sort of approach these decisions.
Right. Well, so yes, and I'm sorry I jumped in a little prematurely. But what I would say is some of this, the thought bubble over my head is there are these young women who, there's this intersection of being a young woman advocating for herself in a medical setting, right? And sort of a more, everyone's nodding, yes, because it seems very paternalistic and you're just going to do what you were told to do. And, I'm very grateful as a clinician, as a physician, that we've gotten away from that and that we have shared decision making, right? Because I think that knee jerk of, well, you have to stop everything, or is because you're going to sue me, because if something goes wrong, it's going to be on me, but I think that's sort of not, nothing's a sure thing, right? We all you can do all the right things, whatever that is, and do every safe thing, and things might still not, we still might not have a great outcome. And that's terrible and regrettable, but I think it shouldn't preclude us having conversations about what people's values are and what their obligations are and those kind of things. So I think some of it is even not related to narcolepsy, but just sort of reminding people that you get to be the driver of your own healthcare, and that you shouldn't feel uncomfortable asking questions and so forth. Thank you for coming to my TED Talk about that. Yeah, right. There's that part of it. I think, there are definitely medications that we know are not as safe. So modafinil has been shown in a couple of studies to have a little bit of an increased risk, as Emily mentioned, especially during the first trimester. So, whether you could go back on, if modafinil is the greatest med for you, once all those organs are formed and you're just, growing that little person, that might be a great option. But it does look like being on that medicine really early in pregnancy is a risk. You mentioned Ashley, methylphenidate. So the Concerta is a methylphenidate product, and that there's a ton of data that this looks pretty safe, and that also it's something that you could stay on during lactation because very little of it gets transmitted to breast milk. So that's, I think, another thing I'd like to say is that it's not true that there's no data. And then, the other thing about sort of cohort change, right? Like as things changed for Emily, I'm sure, from the time you had your first child to the time you had your little guy. And so older data shows that people living with narcolepsy were older than average when they had their first pregnancy, that they were more likely to have a higher BMI than the general population. So some of those things, but some of that might be a byproduct. It might not have to do with the narcolepsy. It might be a byproduct of someone who waited X years to get their diagnosis, then finally was like, oh, okay, I feel great. And then being told, well, now you get to choose, or you're going to go off your medicine, or you're going to grow a family. And so delaying it for those reasons when they could have actually not delayed. So it'll be interesting to see in future cohorts whether that age thing, I bet it is not going to hold up, because I think people won't feel like they have to pick one. Yeah.
Thank you, Dr. Sharkey. I wanted to ask a follow-up question because you mentioned some of the meds that do have data, and I'm wondering how you help patients sort of approach medication use for meds that don't have as much data. like the oxybate medications, which are, I think, nowadays quite commonly used to treat both type 1 narcolepsy and other sleep disorders.
So thank you for asking that question. The other point that I wanted to make is this is maybe not always just a conversation with the pregnant person, but if they are parenting with someone else, sometimes it's very helpful to have the other parent there, because it may be that the mom or pregnant, birthing parent is not, they're like, yes, I would like to take my medicine, but they're getting pressure from someone else in the family to say, well, no, you have to stop that. So I think that having realizing that people may want to have that open those conversations to other family members who may have very strong opinions that aren't backed up by any data can be very helpful, right? Like, I invite you to have your spouse come next time so we can look at these materials together, is something that I would very often say, sort of so that I can help advocate even with, in the family, if needed. So you asked about medications where there's not as much data. My approach is typically that I talk about, nothing being completely risk-free, right? And talking about how congenital issues and malformations and those kinds of things are very low, and that we can monitor them, right? So, there are, you can now get like a 3D ultrasound at the mall, right? Of like what the baby, they can practically tell you if they're going to be a redhead or not. So so we can, we can monitor for these things, and, that might be, cause issues. Another thing is if people are worried about like neonatal abstinence syndrome, which is the kind of doctor name for withdrawal. Like if you're on a taking a stimulant and right up until delivery, and the fetus has had some exposure to that, then there might be some, early in the infant, some early irritability or sleepiness, depending on what medication, right? And so, I've definitely had people who decide they're going to taper closer to the time, that they're going to do that withdrawal of the medication in utero rather than after the baby is delivered. So, and really it's about shared decision making and people and what people's values are, and supporting them and saying, we're going to do everything we can to have you have a safe baby. I'm also very fortunate. I work very closely with OBs, and we have, as I said, I'm a psychiatrist and internist by training. So we have colleagues who do OB medicine, which is sort of like they can be in the hospital and sort of work with the obstetricians and gynecologists about like in the moment, like this person is going to have an issue, or we're going to keep an eye on them and round with them. So that's important, because they will do all those level 3 ultrasounds and those kinds of things. And the first time I'll just share one last thought about this, which is the first time I took care of someone who was going to deliver, I said, oh, I got to meet with these. So I went to like a maternal fetal medicine conference, and I was presented and I was worried. And the OBGYNs, you remind yourself, they're surgeons. They were like, I'm making my case, and I'm, really trying, and they're like, we'll get the baby out, right? Like they were not worried. Do you know, right? Do you know what I'm like? They were like, good job, Sharkey. You keep them healthy, and then we'll get we got it from there, right? So I think sort of those worries, you forget that they take care of things that are way more scary and potentially poor outcome related than somebody being on 18 milligrams of methylphenidate. but it doesn't feel like that. So that was very perspective changing for me, because they were like, yeah, whatever. So yeah.
Thank you so much. Yeah, it's sort of a good point that there are multiple members of this team, and that we all bring different perspectives: the patient, the partner, the sleep doctor, the OB. Thank you. Emily and Ashley, I wanted to ask sort of about how your expectations going into your different pregnancies sort of compared to your experience during pregnancy, both in good ways and in more challenging ways. Ashley, maybe you can start.
Sure. So I definitely went into this. I mean, I spent so many years, like I'm sure many people on this call or parents, like worrying about how many ways things will, what will go wrong with cataplexy, what will go wrong with narcolepsy. I made like my entire birth plan, like huge letters, like has narcolepsy, like wanted them to make sure to know, like in case I fell asleep or something. Like I feel like I don't know. I think what you just said, Dr. Sharkey, is like to a good point. Like they've dealt with so much more than just someone with narcolepsy. So I really worried that like cataplexy was going to be a problem. I worried that, when can I take my medications? Or will I just be too tired to do anything? So I definitely came at it in that sense of just being like very assuming I would be like a failure at most things unless I worked extra hard because I have narcolepsy. But I would say a few things. Number one, that like, I guess, so some bad things that I would say like from pregnancy that I maybe like did fear and was like, if you fall asleep holding the baby, like feeding, because I breastfed both of my boys and it put me to sleep every time. Like it's just so tiring. But what was nice about the support groups and stuff was like learning from other moms about the breast friend, or like just making sure my husband knew like I was always in a safe space. I made the room like so I had like either a bed or a chair. Like I never like put myself into a situation where I knew I could potentially like be holding him and fall down. Like we know how to live with narcolepsy, so you just do that also with the baby. So I think the hard part for me was that, and that did live up to my expectation of being hard. But one thing that like I said, I feared all these different things, and none of those things happened. Like you just said, Dr. Sharkey, the OBGYNs were like, yeah, no handle, or the anesthesiologist. I'm like, well, if I get cataplexy, this is what you do. He's like, no, we'll handle it. We know how to do this. Like, there's literally no worry. And so the great part I think about having narcolepsy was that I was not prepared for the fact that, we're pretty good at not sleeping well. We're pretty good at being able to take a nap in 5 seconds. So if someone came over to help me, I could just lay my head down, take my quick nap and, feel better. Like I'm already good at being up at weird hours. So that was super helpful, I feel like, because it didn't feel different to me. Like I hear a lot of people complain about how tiring pregnancy is and stuff like that, but that's just like our normal life. So yeah, I was definitely more tired with pregnancy. But I think I gave myself more grace to like take those opportunities to take naps, and you have that excuse of I'm pregnant. So I definitely feel like a lot of things I feared didn't end up coming to be true.
You're so right about the sort of unique skill in being good at being up at weird times and napping, on command, and how I imagine that's actually works out pretty well, especially in the infancy period where, your sleep schedule and your baby's sleep schedule might actually be pretty aligned.
Yeah, it's great. Good cuddling naps.
Yes. Emily, I'd love it if you could speak to the same thing, sort of how your expectations compared to your experience and some sort of more positive aspects and more challenging aspects.
Sure. Yeah. And I also, I guess, have the advantage of having multiple experiences, which were all pretty different. And so, like I mentioned, I did discontinue medications once I had positive pregnancy tests. And I just anticipated that I would be, from 100% to 0% when I went off my meds. And I am principally medicated with oxybates, which I do fairly well on. I still do have pretty regular cataplexy, but it's manageable. And so I just anticipated feeling like totally wiped out. And some of you have been there when you're like anticipating stopping your meds, like when you're anticipating that first night of not having oxybate to put you in that sweet, dreamy sleep. I just remember those times because that first morning you're like, oh, like, you didn't sleep well. But surprisingly, like my daytime symptoms were not as bad as anticipated with my first pregnancy. And I think Ashley kind of mentioned some of the some of the accommodations you kind of put in place for yourself, more napping and just more leniency with your schedule if you're able. And I think especially because it was my first pregnancy and I was a graduate student at the time, which also afforded some flexibility, it made it manageable, surprisingly manageable. And so I just anticipated they'd all be like that. I'm like, okay, I can do this. I'm a little more sleepy, but I'll take more naps. But chasing a toddler around doesn't really help. And once you have small children, you just are forced to live more on the schedule of other people. And so those pregnancies became increasingly difficult. I think the second was more difficult, like I said, because there was an increased demand, both physically and emotionally. And then the third pregnancy was like surprisingly hard, and I don't really know what to attribute it to. There was like a 5-year gap between my second and third, but just like my cataplexy was much less controllable. I was so sleepy, but again, I had determined in my mind this black and white, and that I was just going to grit my teeth, like Dr. Sharkey said, and muscle through. Whereas I think going back, and it wasn't just like my well-being. It was arriving to work in my parking space and just like immediately having to recline and taking a half-hour nap and waking up, and like, I'm sure you can probably all relate. You're like, what route did I take? Like, and just like not realizing how sleepy I was because I was so sleepy. And so there were differences and challenging differences. And I also just kind of like made my accommodations by myself. I would find empty conference rooms to take my naps rather than like seeking something more official, which I feel like there are so many more resources out there now to kind of guide people in that. Especially, I was in an academic setting, and I think I could have done more for myself, which I would recommend to others. And like I was in a situation that fortunately was flexible enough that I could have control over my schedule. But I don't know. I mean, we all deal with the stigma or perceived stigma and concern about productivity and what people are going to think of us. And I admire people who I've encountered who just have the self-confidence to acknowledge their needs and have those needs met. And I think when we come with that attitude, rather than like apologizing for what we need, then workplaces and academic institutions will be accommodating. That's not to say, I mean, I've heard of people having really rough experiences seeking accommodations as well. So I understand the dilemma, but I could have done better for my own symptoms. And so that's my experience.
I'll also add to that sort of point about accommodations, a reminder to everybody that accommodations are your legal right. So if you have a chronic illness or disability and you have things that require accommodation, your employer or school, wherever you're at, must make reasonable accommodations. Of course, that doesn't make it any easier to advocate for yourself and broach that conversation, but it is your legal right. Dr. Sharkey, do you have anything?
Yeah, I was going to jump
in to add. Yeah,
I talked to, not just in the context of pregnancy, but I talk to people about accommodations a lot, right? Because I think that when a medical provider writes a letter, it can be really helpful, but that's something I always write with the person, and sometimes like not in one sitting, but we sort of think about what does that need to look like, right? So it might be that there's some 9 o'clock meeting that you always have to go to, right? So you don't want to say this person doesn't have to come till 10, right? You want to sort of, so I always try to collaborate on those and really make them have the right amount of detail, but also the right amount of flexibility, and not to try to put something in that that's going to not be compatible with the workplace, and you're all nodding, right? Because it's like, you know that you want to make suggestions that are going to be helpful and that also can actually be put into practice. So I think that's a big thing, is like working with a provider to write up accommodations that are going to be super helpful. And maybe the provider has ideas that you didn't think of, right? So that's the other thing. Like I've helped you all have lived with narcolepsy. I don't, but I have the advantage of having probably taken care of a lot of people and said, oh, well, this is how this workplace did it or whatever. So.
Ashley, were there any accommodations that you found particularly helpful, either during your pregnancy or afterwards?
Yeah, definitely. I mean, I'm just a huge advocate in general for like the best medicine you can use towards narcolepsy is advocacy, because, you know, if you don't say something about it, or if we don't ask, then you're kind of just suffering in silence, and it makes it look like your work's not being done, or it makes it look, but if with very simple accommodations, we can function just as well as anyone else. So I've always, from the start of my pregnancy, I mean, from start of narcolepsy through pregnancy, all those things, I've always asked. I've worked with my doctor to create a list, and I always like just threw anything on there that I could think of, because I always know I'll probably back down a little bit when I go to actually ask for that. So I've always told them, like, I'm open with them that every day I will obviously take my 10-minute nap, and if I need it, I just take it. They have curtains in my office, so I can do that. I mean, there's not like a set space or anything, but I mean, obviously I can nap anywhere, so it's fine. But I definitely always did that. And then, you know, work from home when I need to. Like the driving is obviously a serious concern, and obviously something any doctor will agree with. So working from home when I can is great. And yeah, I just try to be upfront about it in general, just especially when I was pregnant, because I didn't want people to think I was being rude at a meeting if I fell asleep or something like that. Like, it's not what I'm trying to portray. It's just like, I just really can't help it. So I think pregnancy probably helped me feel more confident about asking for those, because you say, well, I'm pregnant and I have narcolepsy. So I mean, I'm always a firm believer in getting, you know, updated requests or anything that you feel, if something changes, like let them know. And if they're not accommodating to that, like Kelsey said, it is your right, and maybe that's not the right place for you, because people will be accommodating, and you know, you're worth that.
Thank you so much, Ashley. Before I look at the questions, I know Ashley had briefly mentioned her experience with breastfeeding, and I wanted to give you, Emily, an opportunity to share what your experience was like during breastfeeding.
Oh, she's muted.
There we go. I apologize. Yeah, for sure. Being sleep deprived with narcolepsy and without medication and with a new baby has its challenges, for sure. I remember being sleepy in scenarios where I probably could have slept more safely or planned ahead better. Ashley mentioned some of the great ideas, like engineering controls, I guess I could call them, for sleep in cataplexy. Having a safe place to put the baby down, taking your naps on the floor, where the baby may be laying or playing, and then where possible, prioritizing your own sleep, and so that you to decrease symptoms during the day. So for my first two pregnancies, I breastfed all of my sons, but I stayed off of oxybate for the first two pregnancies, because there wasn't a lot of data on how oxybate is transmitted in the breast milk. And I had the opportunity actually to do research on that with Dr. Sharkey, to give us a little more information about how long oxybate is emitted in the breast milk, which allowed for me to go back on oxybate a lot sooner with my third child. And that was a total game changer. I don't know. I mean, granted, I didn't have a toddler while I was caring for my third infant, but it was like night and day compared to my other pregnancies where I was breastfeeding unmedicated. And so that was so refreshing to be able to be back on meds, and just helped me to feel like I could be so much more present. You know, I think you often don't realize how tired you were until you're alert enough to look back. And so I am happy to share more about my experience and about that data that helped me feel comfortable and confident going back onto meds during lactation. But that's some of my experience, and I look forward to seeing some of the questions. So I'll stop there.
Great. Dr. Sharkey, anything you want to add about
I'll let
breastfeeding?
you do questions.
Okay, wonderful. So we have a couple participants who are curious about labor and delivery with cataplexy, including one person who was told that her daughter would need to have a C-section because of her narcolepsy.
So I can speak to that. I think there's, the biggest data series that I've seen is in 414 deliveries, and in those 414 deliveries, there were 3 episodes of cataplexy. So most people with narcolepsy give birth vaginally, and cataplexy that was less than 1% of the deliveries. So I've read one case report of status cataplecticus. So, but it's really much more likely that somebody will deliver vaginally and they don't need a C-section. So whoever said that could be educated gently.
And I'll just add, that was one of my greatest fears. I had pretty pretty profound cataplexy, and we included in the birth plan, and my husband informed them, and he would know obviously what it looks like, and that was a big concern. But it wasn't until after it was all over, we looked at each other and we're like, you didn't have any cataplexy, and so fortunately it didn't end up being a trigger for myself.
Yeah, I agree. I mean, I didn't have any, and I feel like from all the support groups I've gone to, I don't think I've heard of anyone, maybe someone, but I definitely think if you want your birth plan to be some way, write your birth plan the way you want it to be and just advocate for that. Because like Dr. Sharkey said, and everyone here has said, the experience, once you get in that room, they're like, yeah, we'll handle it. It's not going to be a big deal. There's medical professionals there. And so if you want to have vaginal birth, work as much as you can to do that. I feel like that's something that we tend to hear a lot, oh, well, because of that, we're going to do this. And I feel like I used to hear that when I started this journey, but you can advocate to, what you want.
And here I'll chime in again as a physician and say, if you cannot have surgery, major abdominal surgery as part, right? Yes. I mean, of course, when a C-section is indicated, it's indicated, but the things that make it harder, it's hard, even if you don't live with narcolepsy, then it's hard if you have narcolepsy. And then, having had, an incision in your belly, to be avoided if you could. Yeah.
Thank you. The next question is about how you approached disclosing your narcolepsy, and if you disclosed your narcolepsy prior to your pregnancy. Probably for Ashley and Emily.
Yeah, so I disclose I'm probably an annoying person to most jobs that I work with, because I feel like that's just how I've learned to deal with narcolepsy, is to be upfront. So I've just always disclosed my narcolepsy right up front, because like I said, I just don't want to look in the line of work that I do. I just don't want to look rude when I'm in meetings or possibly fall asleep, things like that. So I disclosed prior to my pregnancy, and I think that obviously helped when I was pregnant to ensure that they obviously adhere to any of my accommodations that I had, because I had narcolepsy on top of pregnancy. So if you can, and if you're comfortable doing so, I feel like it is really helpful. It takes a weight off, and your doctors can help you with that. They can make that less. And so yeah, I think it's just a helpful tool.
Yeah, I had 2 supervisors, and I disclosed to the supervisor who I was having more FaceTime with and working in an adjacent office, and knew that I would need to leave and find a space. And fortunately, he was supportive. But I mean, it's easier said than done. And I've known plenty of people who have challenging experiences with their disclosure. So I understand that people put a lot of thought into it. And I think the peer support groups can be really helpful to attend and hear how others have approached that. Katie, I did see some like more medical science-based questions about exposure that might be helpful. There was one about heredity of narcolepsy.
Yeah, so the hereditary, is it okay, Kelsey, for me to answer that one?
Yeah, please.
So what's the probability that a baby will get narcolepsy because of heredity? What I would say is we definitely think that there is a hereditary component to narcolepsy, and that it especially type 1, that and there's a lot of data from people like Manuel Mignot and so forth that support there being a genetic component, and then that is likely amplified by some kind of exposure, perhaps to a viral insult. That's kind of, I think, one of the leading theories. You all are nodding. So I wouldn't say that there is a direct, genetic transmission of narcolepsy. And there isn't any. A related question, I guess, would be, does just having narcolepsy make you have a more high risk pregnancy? And the answer appears to be no. So there's been a bunch of like case control studies or studies of people who were diagnosed or their symptoms started after they had they had their child and then their narcolepsy started, and no difference in outcomes, pregnancy outcomes based on that. So narcolepsy per se doesn't appear to cause additional risks to a pregnancy.
Thanks, Dr. Sharkey. Emily, I know you had mentioned your willingness to share the specifics of your research about medication during breastfeeding, and I do think people are curious what the data is on oxybates and breastfeeding.
Sure, yeah, and I know we're sharing a resource page, and I didn't think about adding that to the resource page, but basically ours and another study have shown that oxybate is in the breast milk kind of similar to in the bloodstream. And so like 4 to 6 hours after, our study showed that 6 hours after taking oxybate, the levels of the active molecule gamma hydroxybutyrate have returned to an endogenous level. Endogenous meaning the level that it already exists in breast milk, because we make that molecule naturally. And so it should be safe after 6 hours. So I myself opted to delay my breastfeeding until I had escaped that time window. So for some people that might mean expressing and discarding. That's like so painful to do. And I did some of that. I fortunately had enough of a supply that I could also just delay the number of hours that I needed to delay after taking the medication. I've known women who take oxybate, and when they go back on, they go on one dose only. And so they get a better sleep than if they weren't on a dose at all. And then by partway through the night and in the morning, they feel comfortable breastfeeding. And so I encourage you to look up that information. Again, I'm sorry that we don't have the paper posted here because we're like out of time.
Does this end at 3 or at 3:30?
It ends at 3, but Emily, we can add that to we're going to send this resource page out later.
Okay,
to
great.
Everybody who registered, so we can add that link and anything else we think we need to add.
Good. Yeah, I can provide that for you.
I know
Yeah, Emily's resource on the breastfeeding consequences and all that stuff is super, super helpful for me. And I'm sure many others that have been on her support groups. Not to mention support groups are just so helpful. So thank you.
Well, it sounds like we are at the end of our hour. So Monica, I'll pass it back to you to wrap things up. Thanks, everybody.
that sounds great. This was amazing. Thank you all. I just want to thank everybody on this panel, Ashley, Starr, Frechette, Kelsey Biddle, Emily Barker, and Dr. Katie Sharkey for sharing your experience with this topic, maternal health and narcolepsy. Thank you again to our sponsors for enabling Wake Up Narcolepsy to bring the Brown Bag webinar series to the community. Thank you to our Diamond Champion sponsor, Jazz Pharmaceuticals, our Gold Champion sponsor, Avidel Pharmaceuticals, our Silver Champion sponsor, Harmony Biosciences, and our program sponsor, Takeda Pharmaceuticals. Everybody can expect an email once the video is edited, and we will share the resource page as well. So thank you all. Have a wonderful day. Appreciate this.